Dear viewers, welcome you all to our show OSA, that is Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is Ilizarov's method for tibial fracture in children, a highly demanding topic. And as well as we have three learned academic experts as well as an highly efficient speaker. Dear viewers, today our academic expert is Professor Mafakkarul Barisar, the legendary orthopedic surgeon of Bangladesh. I would like to request Professor Mafakkarul Barisar to join with us. So welcome.
Thank you, Tanvir.
Dear viewers, we have two learned academic experts. One of them is academician, a highly academician, Professor Novikov sir from Kurgan, Russia. I would like to request Professor Novikov sir to join with us. And another one is Dr. Shamsul Huda sir from Patna, India, very enthusiastic Ilizarov surgeon. I would like to request both of them to join with us. So welcome.
Dr. Tanvir, thank you.
Dear viewers, we have our speaker today, that is Professor Anatoly, and he is the head of Children's Trauma, Ilizarov National Medical Research Center for Traumatology and Orthopedics, Kurgan, Russia. I would like to request Professor Anatoly sir to join with us and share his screen with us. Professor Anatoly sir, would you please share your screen with us and start your presentation?
Good afternoon. I'm ready.
Yes, sir. Good afternoon, sir. Please start your presentation, sir.
Dear colleagues, I'm honored to be a lecturer at the Assembly webinar. Today we will discuss treatment of tibial bone fractures in children by the Ilizarov method. Fractured tibia, frequent trauma in childhood. A large number of complications that occur in the treatment of these injury cases. Discussion among child orthopedics. Among treatments, the main ones are casting with or without closed reduction, flexible intramedullary nailing, plate osteosynthesis, external fixation, rigid intramedullary nailing. Potential disadvantages for casting with or without closed reduction. Recurrence frequent follow-up with radiographs to monitor for displacement. Prolonged immobilization and cast scar. Prolonged weight-bearing restrictions. Secondary displacement. Malunion. Compartment syndrome. Potential disadvantage for flexible intramedullary nailing. Implant irritation. Second surgery for implant removal. Prolonged weight-bearing restriction. Secondary displacement and malunion. Compartment syndrome. Potential disadvantages for plate osteosynthesis. Large incision and surgical exposure. Implant irritation. Second surgery for implant removal. Potential for wound complication. Potential disadvantage for rigid intramedullary nailing. Second surgery for nail removal. Anterior knee pain. Advantage Ilizarov method. Anatomic closed reduction. Fracture stability even in presence of comminution. Small incision allows for management of hard soft tissue injury. Early air burn and range of motion. Management of bone fragments during treatment. Visual avoiding no retained implants. In our clinic, indication for operative treatment of tibial fracture children are as follows: open fractures, unstable fractures, including angular varus displacement and intact fibula, polytrauma, flotating knee, led obese children with difficult cuts. Operative technique. First step, patient's position on the operating table with traction by foot. Elimination, displacement of bone fragments. Radiograph AP and lateral rotational displacement must be removed. Inserting percutaneous instrumentation from safe zone reduce the risk of damage of neurovascular structure. Two-step. Sequentially install the proximal ring, then the distal ring, and then the intermediate ring. Three-step. We connect ring. Applying now techniques, we produce the final reduction. Fourth step, final fixation. In our clinic, an analysis of case of tibial fracture in children over the past 10 years. The highest number of cases was observed in boys aged 8 to 14 years. The most common fracture were type 42D5.1 and 42TD5.1. Inpatient treatment. Duration of pain syndrome 3-7 days. Weight bearing and range of motion 70 days. Length of stay in the hospital 18. The duration of fixation was determined by the age of the patient and the severity of the injury. According to the criteria Flynn, poor treatment result we not noted. Excellent 80% and satisfactory. Complication: superficial infection, pin tract infection, 70 case, 60%. Delayed units, 4 case, 4%. Only 2 cases required antibiotics. All cases delayed units of open fractures with T-Lot 2. Clinical case: Boy, 9-year, diagnosis, closed fracture of the tibia. X-ray analysis. Before operation, 2 days after operation, after removal of Ilizarov apparatus. Two clinical case. Boy, 40-year, closed reduction, closed fracture of the tibia. X-ray analysis. Before operation, 3 days after operation, after removal of Ilizarov apparatus. Boy, 50-year, open multifragmentary fracture of the tibia, posterior 2. X-ray analysis. Before operation, 3 days after operation, after removal of Ilizarov apparatus. Conclusion. The use of Ilizarov apparatus in diaphyseal fracture of the tibia in children provides an anatomical reposition, eliminates secondary displacement, and allows etching consolidation with restoration of correct anatomical parameters. Osteocentric by Ilizarov apparatus is functional, where restoration of the full amplitude of movements in adjacent joints and porosity occur without the first move after the operation. Osteocentric by Ilizarov apparatus eliminates damage to the growth plate and does not affect subsequent growth. Complication observed when using Ilizarov apparatus did not require rehospitalization and did not affect the end result of treatment. The use of Ilizarov apparatus in the treatment of children with shin fractures made it impossible to obtain excellent and good treatment result in 100% of cases. This 7-year-old girl show sorry. This 7-year-old girl show is the restoration of function of the left lower limb after tibial fracture. 12 days have passed since surgery. Method Ilizarova is very good operative technique for fracture of the children. Thank you.
Thank you very much, sir, for your excellent presentation. Now, I would like to request Professor Mafakhrul Bari, sir, to say something regarding the Ilizarov method for tibial fracture in children.
Анатолий Карабейников. Слышно?
Да, Борис?
Okay.
Да, хорошо.
So thank you very much for your excellent you have shown, because I love to do the Ilizarov in children, adolescent, and adult. But in your lecture, you have done closed fractures and open fractures. Open gastulo 2, you have not shown any case of gastulo 3B, exposed bone. What about the exposed bone? Bone is totally visible. Then you have not shown even the single case. Gastulo 3B, exposed bone. What do you do that with the Ilizarov, or you take the help of plastic surgeon? Gastulo 3B.
Когда у вас разможденный 3B, как вы оперируете?
Когда вот костей полностью видно, а что вы делаете тогда?
Открытые, как закрываете?
Нельзя закрыть вот мягкими тканями. When you don't,
Барри, можно на русском?
Он так и сказал.
Да вот я же говорю, вот, когда кости видно полностью, да, exposed, вот кости видно, вот мягкий ткань вы не можете закрыть. А что вы делаете тогда?
За последние 10 лет у нас таких случаев не было, но если бы это случилось,
да.
Если бы это случилось, то, наложив аппарат Илизарова, мы попытались бы уменьшить размер раны за счет дублирования костных отломков, как один из методов.
И вы берете вот помощь пластического хирурга?
С пластическим хирургом работаете?
Нет.
Нет.
В остром периоде нет.
Сейчас я говорю, вот друзья, которые пеналисты есть. I asked the questions, gastulo 3B, when bone is exposed, what do you do? His answer is, for the last 10 years, we don't get any gastulo 3B here in Kurgan. If we get that kind of gastulo 3B, then for children, then we take the help of the plastic surgeon. Okay?
Okay. That's great, sir. But we are facing, we are having the gastulo 3B more than 10 or 15 cases in each and every day in our country. So there is a different scenario in every part of the world. We have to manage our patients according to the need. Sir, do you have any suggestion, Professor Barisa? I would like to request, is there any need to do Ilizarov in case of closed tibial fracture, especially in case of children? Do you agree with this sort of procedure, or do you prefer plaster cast in case of children?
It depends. It depends depending on the case in every country. But I'm telling you, in Kurgan, they love to do in children, in adolescent, even in clothes, by Ilizarov technique, because you can reduce the fragments, it gives stability, and for children, Ilizarov, fantastic can very nicely move with the Ilizarov apparatus. And in my country also, if it is 2 years, 3 years, 4 years, I don't go for Ilizarov. If 7, 8, 9, 10, 11, even in closed fractures, I go for Ilizarov, both bones. Because very easily, patient can walk with the Ilizarov apparatus. I do that. I basically principle of Ilizarov, but not all the time. It depends if patient is poor, patient cannot afford, then I go for plaster also. That is also not strictly that I am totally go for Ilizarov, but I love to do that. But on the basis of different cases from different places, if patient is poor, then I go for plaster immobilization. You understand?
Yes, sir. I understand, sir. In case of plaster cast, we usually give a back slab in the first 7 days, then we will do the full plaster. But what we will do in case of Ilizarov, when we will put the Ilizarov, the
it-
day 1 or day 5
day
or day
one,
7?
you can put the Ilizarov. Day one, nothing to be worried. Nothing to
How
be worried.
long? Okay, so then how long we will continue the Ilizarov? 3 weeks or 1.5 months in case of tibia?
Dzień dobry.
How long?
Давайте через час.
How long
Полтора.
we will put the Ilizarov for the children? Is it for 3 weeks or it is for one
No,
and a
no.
half months?
6 weeks to 2 months. You see why I am telling that. In case of children, any kind of deformity, starting from the 6 months, 8 months, 9 months, whenever patient comes with deformity, 6 month old, 1 year old, or 3 years, you can easily put Ilizarov in deformity cases. And that's why they are using in open case, this is obvious, in all open case, I do Ilizarov in children. Because with biocompatible thin words, it is very easily, you can put Ilizarov for children with open fractures, all open fractures, including gastrilo 2, gastrilo 3A, and gastrilo 3B. And I'm doing all the time that. But in close, depending on the cases, I told you, if patient can afford, then you can do the Ilizarov. If not, then you can go for plaster immobilization. Even I'm telling you one thing. The main task, Professor Shepsov, first time when I met him in 2003, he told me our task is the movement all the time with full weight bear. That's why we love to do the Ilizarov. With plaster immobilization, you cannot weight bear. After 72 hours, you can tell your patient, yes, you can weight bear. But that may happen your displacement. But with this Ilizarov apparatus, your fixation must be stable and you can do that. And healing process is very good. And for children, is very nice.
Okay, I think there is a network problem in case of Professor Mofakhar Bari, sir.
So, Dr. Tanvir, what do we normally we do either a plaster cast or a tensional in children if it is displaced? What is the
Okay.
protocol that you do?
Anatoly, you follow me? This
Да,
is,
Барри,
this,
слышу.
this is a learning for the young orthopedic.
And you
Yes,
heard
I
us.
think
There's a network issue.
there is a net problem there. Yeah,
Noviko,
Dr. Shamsullah, sir, yeah. Please,
Close
Dr.
fracture
Shamsullah, sir,
children, why
please.
go?
Yes, normally
I
in
want little bit explain
India, in
about-
children fracture, we go for either plaster slab and cast, and if there is a trauma, displaced trauma, we go for a tensional added with plaster. So we don't usually do Ilizarov in children unless it is a grade 3B compound or the Strawberry compound. And even then we try to go with tensional and plastic surgery. But the drawback is that after applying tensional or plaster, the patient has to be immobilized in plaster for a longer time. But as said, Ilizarov gives next day movement. That is a very good device. Can be done even in children also. My question to Bari sir and Noviko sir that in young children in TB in case of panostomalitis or a pathological fracture, what is the protocol, sir? Noviko sir.
And, dear colleagues, I want little bit explain about small story. Few days ago with Dr. Anatoly, we was in fourth city in our country, big city, Novosibirsk. After Moscow, St. Petersburg, and Kazan, this is city with excellent medicine, and you can see just now. This is baby, maybe 6, maybe 7 years old, more than 3 weeks, in the traction. And this is gold standard treatment in the Russia. And you can see, once again, so many patients with traction, fracture of tibia, fracture of humerus, fracture of femur, and doctor in the Russia afraid method Ilizarov because he is invasive. And here doctor says we mini invasive, we pass wire, and if already doctor pass wire, this is humerus, fracture of humerus, and baby 3 weeks in the bed with traction. This is gold treatment according of recommendation St. Petersburg and Moscow. 3 weeks without any movement, go baby out of life, plus add only 3 wires more below and near the fracture, and patient immediately can use this segment, can stand up, can bend, unbend. And for me, with Ilizarov methods, we can support for our patient any fracture, B3, any open fracture, closed fracture, and we can give patients possibilities for activities. For me, for all of the life, I no want lost time. Any fracture we support with Ilizarov methods, but for children we have a special department, trauma department. Only baby, this is doctor can touch. Maybe this is good, maybe no. Dr. Barry is happy because he can support patients from first year in the life and till 100 years. And I think this is depend of doctor, depend of country. But just now we can recommend doctor excellent magic methods for treatment. Ilizarov methods forever. Thank you.
Thank you very much, sir. I have a question to Professor Novikov, sir. Sir, if we put plaster in case of 7 or 6 years baby in closed fracture tibia, then how long you will put the plaster cast for that baby? 6 years baby closed fracture tibia.
Обычно сколько вы держите?
В аппарате?
Нет, с гипсом.
В зависимости от возраста.
6-7 лет, он сказал.
6-7 лет. Это месяц.
I sent your questions for professional, and usually in this department, no more than 1 month. This is depend of fracture, depend of energy of fracture, and usually no than 1 month.
Okay, sir. Then if we put
simple fractures, 1 month.
But in case of Ilizarov, if you put Ilizarov in that same patient, then how long you continue the Ilizarov for the treatment? It is 1 month or more than 1 month?
Вы также месяц держите?
То же самое.
And,
Bone healing, 1 month.
You see, just now we talk about time. Time is same. Plaster cast 1 month, Ilizarov methods 1 month. But during this 1 month, patient can weight bearing. Patient can move in the joint, knee joint and ankle joint. And what is it? This is blood circulation. And when we have time for remove of frame, this is absolutely different tibia. First tibia with plaster cast, atrophic, all of muscles, no work joints, all of joints is dry. Then patient need spend time for rehabilitation for joints, and back for normal life, all of soft tissue. Time is like pregnant. Just now we talk about natural time for healing. And when somebody talk about, oh, just now I will you give no gold tablet and you can get immediately consolidation, this is not good. This is very bad. Time is time. And just now we talk about quality of result. With Ilizarov, quality is great, magic, full.
Самая большая проблема в гипсе. То, что,
So, after removal of the Ilizarov, do you put any brace or any cast?
деформацию.
And just a moment. During plaster cast, sometimes, not all, but sometimes we have second displacement. We have situation when inside of plaster cast, baby jump, baby is baby, swelling is go reduced, change of volume of soft tissue, and then inside of plaster cast we have displacement. After 1 month, consolidation, position like that, must again broken,
Ангуляция.
angulation with Ilizarov methods. If we have any displacement, if we have any angulations, deformity, everything in our hand, we check with X-ray, correction of this situation, little bit fixation, few days, and then we can finish our treatment with excellent axis and excellent function of joints. This is another plus of methods of Ilizarov. Second displacement inside of plaster cast.
Но на самом деле, по нашим исследованиям, 6-7-летних детей не так и много было. Пик начинается с 8 лет, то есть у нас оперативное лечение с 8 до 14 лет больше всего прооперировано.
And this is patients from 6 to 8, small group. Usually for, I don't know why, but many patients from 8 to 14 years. Maybe this is activities and when baby go and spend all time out of family.
Okay, that's great, sir. But we can make a comparative study between the plaster cast and the Ilizarov in case of children. Sir, I have one last question. Do you put any brace or plaster cast after removal of the Ilizarov?
He is understand? Вы что-нибудь накладываете?
Мы накладываем, у детей часто бывает такой эффект после снятия аппарата. Они, когда ходили с фиксированным в аппарате ногой, наступали на ногу. Когда мы снимаем аппарат, они боятся находить. И мы на короткий период накладываем гипсолагету, просто психологически разрешаем наступать на ногу. Это 3-5 дней буквально после снятия аппарата.
Барри, помогай.
What he is telling, after removal of the apparatus, as soon as you remove the apparatus, the patient is afraid. The little boys, 5, 6, 7 years, then for a short period they put a back slap, little bit for 5 days, and then remove that one. Not for a long time. Just psychological support for giving them. As soon as you remove the apparatus, patient is afraid of putting the white beer. That's why for a short period, for 5 or 6 days, they put the back slap.
Okay, sir.
Barry, thank you. У детей старшего возраста мы не накладываем гипс. Сняли аппарат, они встали и пошли сразу. У детей более старшего возраста, adolescent, мы не накладываем брейс. Сняли, removal аппарат, встали и пошли сразу.
Adolescent patients, they don't put their, as soon as you remove the apparatus, they don't put the apparatus, plaster. They just tell the adolescent patient, you can convince them easily with plaster. Without plaster, they can work. And I do also that for adolescent patients. Children is still...
Yeah, no brace even in adolescent patients, sir, after Ilizarov.
No. Whenever you see you have removed the apparatus adolescent. Before removing, you must see the three cortex, always.
Right.
Epilateral and oblique. If you see all the things is very nicely consolidated union, then you don't need to put any plaster.
Right.
But for business purpose, for taking money, you can put. There is another way. See, this is
You want a risk of return.
judgment. Yes, I'm telling you, most of the doctors someday they do that to make money.
Just to avoid the risk of
Good paper. See, Anatoly Karabenikov, he presented a very good paper for young doctors. He will be new. Why close fracture? Sometimes close fracture, you are going for elastic nailing. If you can put elastic nail, why not external fixed Ilizarov? All external fixators are not the same. Ilizarov is quite different than other all external fixators. Less costly, only can wear flexible wear you can use. That is good, very good. And as I would I do that.
Okay, that's great. I think it has a lots of controversy, and we like controversy in case of sharing knowledge.
Yes.
As because of it's a new topic, and I think in the coming part of our program we will discuss about that also. And I would like to prefer one more presenter to present about the Ilizarov in case of fractured children, so that we can know much more things regarding this type of fracture in children. And definitely the young surgeons will take over this Ilizarov in case of children fracture also. Now I would like to request Professor Novikov sir to say something, a last few words regarding our program today.
Thank you very much for Dr. Anatoly.
Thank you very much.
Now we can recommend from 6 years. I'm absolutely agree with Dr. Barry. For 3-5 years, this is not so good, maybe not so good treatment. But from 6 years, we can recommend any type of fracture, closed and open fracture. This is excellent methods. And during the fixation, we can we can remove any problem, including your questions, Dr. Barry, including problem of soft tissue. We can first, with big damage of soft tissue, we can go to the shocking, make angulation for repair, healing of wound of soft tissue. Then continue treatment like orthopedics case, and everything inside of one method of treatment. If patient need plastic support, we can invite this specialties, but inside of Ilizarov treatment, if inside of Ilizarov effect, because with Ilizarov effect we can grow any tissue, bone, muscles, and skin. Thank you.
Next Friday they will talk again. Another topics.
Yeah, he will come, but next Friday we prepare for Dr. Shikhaleva. She will prepare fracture of hand.
Okay.
Oh, okay, so that's
treatment
great.
Fracture of hand by Mini Ilizarov.
Mini Ilizarov. You can. Okay.
That's great.
Okay.
That's great. Dear viewers, thank you very much for being with us. Hope we will see you in the coming Friday with a magnificent topic regarding Ilizarov, the magic of Ilizarov. It may be hand, or it may be in tibia, it may be in Ilizarov. It can we can use Ilizarov in everywhere of the body. And I would like to request Raj TV for helping us to arrange this type of academic program, and definitely Red Pharmaceuticals Limited for sponsoring our program. And I'm Dr. Ilizarov, giving thanks to all our academic expert and the learned speaker for being with us. And hope we will see you in the coming Friday. Till then, I would like to say bye-bye to you.
Thank you.
Bye bye. Bye bye.
Bye bye.
Bye-bye.
You are
Bye.
watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.